Chiari malformation. And what I'm going to present comes from the updated literature and also by my personal experience on these very challenging and difficult topics dealing with craniovertebral junction spine neurosurgery. First of all, just to remember, to refresh what for me is always difficult to remember, the new classification of Chiari malformation. We have too many different types of denomination of different clinical status. Many years ago, we had only Chiari 1 and Chiari 2, then Chiari 3, Chiari 4. Right now, we have Chiari 0, which is a non-Chiari, a non-syringomelia condition, but with a crowded posterior fossa. And we have also 0.5 Chiari, which is syringomelia standing alone. We have also type 1, the well-known Chiari condition, which is a complete or partial herniation of cerebellar tonsil at least 3 or 5 millimeters below the foramen magnum. Type 1.5 is the same of 1, but with odontoid retroversion and without spinal dystrophism. Type 2 is a more consistent herniation of tonsils, vermis, pons, with spinal dystrophism and hydrocephalus. Then we have type 3, which is an occipital cervical hernia, and type 4, aplasia or hypoplasia of cerebellum. So we have once again to remember which is the Goel paradigm. Goel states and always confirm, also in the last webinar of a couple of weeks ago, that Chiari malformation doesn't exist. In other words, it exists Chiari formation. And Chiari formation is the consequence of some etiological, very special feature. Very simply, the most known type of Chiari are type 1 for general young adult people, and type 2 for generally childhood patient. Type 1 less severe, type 2 more severe. Type 2 is associated with many others conditions like hydrocephalus or also tether cord and myelomeningocele and etc. This is an example of an impressive, awful Chiari 3 malformation. Fortunately, we have not so many opportunity to meet in our career some monsters like that. Etiology for Chiari are small posterior fossa, hydrocephalus, craniosynostosis, abnormalities of the upper cervical spine. I must remember basilar invagination along with Kippel file occipitalization and the C1, C2 instability, which is a specific topic of Atul. And finally, arachnoid fibrosis around the tonsil. But first of all, the posterior cranial fossa crowded, so-called crowded posterior cranial fossa is the primum movens of Chiari malformation. And this observation drives the way to perform posterior fossa decompression according to the special malformation of the cranial fossa. That means that the decompression should be more according to the craniocaudal extension of the malformation. This malformation counteract also the normal CSF dynamics. As we can appreciate on the left panel, we have a turbulence, meaning that there is a reduction of CSF flow spaces. So the flow has to increase in velocity as a consequence of a decrease of the absolute value. And this is another important observation. Let's start. with the core topics. Who we have to operate? Patient symptomatic. When? As soon as possible. Sometime in pediatric, in childhood, it must be preventing more than curative. And how? With bone decompression, anterior, posterior. When dealing with settings, huge decompression with duroplastic, and we will see. But surgical indication is all comes from a clinical indication. Don't forget neuropsychological function as a driving indication for Chiari, which is a Cinderella clinical component. Suboccipital craniectomy. We consider suboccipital craniectomy a less invasive surgical approach when we perform bone removal along with sparing of the dura or just dura delamination. Dura delamination is a way to enlarge the capability of elastic compliance dura without performing a duroplasty. Also, Catholic University, the place where I work in, has a huge experience in pediatric transverse micro incision of the outer layer of the dura mother as an important alternative treatment to duroplasty. Number two, we have craniectomy and durotomy with arachnoid preservation. Very strange, but also interesting aspect of a surgical armamentarium. In this book, including many experience of my friends and very expert craniocervical junction surgery, we have this experience of Professor Spallone, to which I co-worked, with durotomy with arachnoid preservation without closing or suturing dura mother. What happened? Good earning of posterior cranial fossa space, but also CSF leak, which with time tends to absorb spontaneously. A third type of surgical strategy is craniectomy and dural patch. We all know that dural patch can be autologous, like pericranium fascia lata, or heterologous, like cadaveric dura, or synthetic, like Gorotex. Then we have a chance, which is craniectomy, tonsils coagulation, arachnoid debridements, obex opening, and dural patch. When we have to propose this strategy? When we deal with intradural membranes, veils, pouch removal is important to rehabilitate the posterior cranial fossa CSF space deteriorated and compromised by infection, arachnoiditis, malformation, and similar condition, all with duroplasty. And we also know that this strategy is very effective in the Kyary malformation associated with the syringomyelia, more likely type 2 Kyary malformation. But what strikes our soul is that we have an improvement no more than 50%, both for syrinx, both for Chiari symptom. That means that this is not an 100% effective surgical strategy. You know, every schools, every groups develop different way to deal with craniectomy and opening of the dura and arachnoid debridements and manipulation. And I think that most important thing to stress is that CSF fistula in this case occur in about around at least 6% of the cases. And the literature states that there is a significant lower recurrence rate when we open the arachnoid in such a strategy. Then we have the anterior decompression strategy that deals with the observation that the association of Chiari 1 and basilar invagination is the most common craniovertebral junction disease in adulthood. In our paper of some years ago, we published a very strange, like an experimental model we had to face with in clinical practice. Dealing with a young boy with basilar invagination with platybasia type A or type 1 according to Goel classification, with posterior C1 bifid arc and Chiari malformation. As soon as we performed a huge decompression of odontoid anterior arc of C1 and all, I underline all, the clivus up to the synchondrosis with the sphenoid bone, we had a disappearance of Chiari and clinical restoration of the patient. Nevertheless, in the following months, surprisingly, both the odontoid and the clivus regrowth, reproposing the posterior cranial fossa crowding, and also Chiari malformation, in this case, according to Atul Goel, formation as a result of crowding of posterior cranial fossa, reproduce all the clinical and neuroradiological condition. Very interesting experimental model in clinical practice. Then we have to deal with settings with different way. We all know that settings can be classified according to the fact that it could be associated with Chiari malformation or foramen magnum crowding in type 1, or like type 2 without disease at the foramen magnum, so-called idiopathic syringomyelia, type 3 associated with spinal cord tumor, traumatic myelopathy, spinal arachnoiditis, myelomyelacia, and type 4 pure hydromelia. In the literature, when we speak about settings associated to the Chiari type 0 classification, that means syringomyelia without tonsillary ectopia, and we have to decompress posterior cranial fossa because crowding of posterior cranial fossa still is the driving force for these clinical and neuroradiological pattern. And the way to decompress, according to this algorithm, is the well-known syringostomy or internal shunt. We have to remember that the syringomyelia is associated in some cases of Chiari according to a genetic algorithm clearly identified in the past. Then we have Chiari malformation associated with other pathologies like hydrocephalus, tethered cord, and idiopathic intracranial hypotension. This is a very typical case of a cured hydrocephalus. When the shunt works, no problems at all, no Chiari, no syringomyelia. But when we have a malfunction of CSF drainage, we have recurrences of hydrocephalus along with syringomyelia, along with Chiari malformation. And when we cure, we operate, we revision, we do redo surgery of shunt, we cure everything. So to cure hydrocephalus in these cases means to cure Chiari and associated disease. Let's go to the end of this presentation, focalizing another interesting association, Chiari and tether cord syndrome. We all know that in these cases, posterior cranial fossa has a normal side. So the concept of a crowded posterior cranial fossa doesn't work anymore in this case. All we have to do is to detether the cord. But to detether the cord accordingly to the clinical and the neuroradiological pattern. Nevertheless, there are some different institutions that deal with this topic in a very 100% Chiari malformation management spirit. And this is associated to the fact that this center developed a very interesting and intriguing way to deal with the tethering procedures with both intradural, extradural way to identify the filum terminalis. But the Italian Society of Neurosurgery had official critical position with this way to manage this very special type of Chiari malformation. Then we conclude with a very unusual case of a Chiari malformation or formation, according to Atul, the idiopathic intracranial hypotension. It's a very strange, relatively unknown clinical condition in which we have a low CSF volume rather than a low CSF pressure due to traumatic, old traumatic or chronic traumatic condition producing epidural CSF collection with nerve root or perinerval root collection, and the draining in multiple sites the CSF like artificial or post-traumatic internal CSF shunt, which produce a sagging of the brain. And the way to deal with this condition is to be conservative with bed rest, caffeine, and fluid restriction, or epidural blood patch, or even if with fibrin glue or blood, or sometime with surgery. Let's remember which are the neuroradiological more frequent findings dealing with this rare and relatively unknown condition. Number one, subdural fluid collection, like hygromas, occasionally hematomas, or enhancement of pachymeninges, uniform or diffuse, or engorgement of venous structures, or pituitary hyperemia, or sagging of the brain with a descending cerebellar tonsil, secondary Chiari malformation, and bowing of optic chiasm and flattening of the pons. Conclusion, which is the take-home message of this brief summary of all the surgical armamentarium available in the literature and personal experience. When we deal with the Chiari malformation type 1, with asymptomatic clinical picture, maybe conservative approach is the best. Otherwise, Chiari malformation type 2 is always associated with hydrocephalus or myomeningocele, huge herniation of the content of posterior cranial fossa in the foramen magnum, generally associated with a very eloquent symptomatology. Surgical strategy is strongly recommended. Nevertheless, concluding with the literature, when we deal with the literature data, we have a contradictory position. In this paper of 2009, opening the arachnoid associated to 50%, 48% of recurrency. Nevertheless, in this other experience published on neurosurgery 2012, opening the dura and opening the arachnoid is significantly associated with a lower recurrence rate of neuroradiology and symptomatology. And this is a slide I had taken with my mobile during the beautiful consensus congress hosted by Dr. Laura Valentini in Milan, the same town of Maurizio Formari, and I took with this camera these slides, which is a very short abstract of this presentation. When we deal with the Chiari associated with the syringomyelia, 100% of agreement of the audience is in favor of bone decompression duroplasty. A watertight closure is strongly advocated in order to avoid CSF leakage, which is the main concern of duroplasty. And to conclude, I'm a reviewer of papers, as you all are. As a reviewer, I think that to review today a paper dealing with Chiari malformation could be absolutely a real challenge. Too many data, many of those contradictory. We have to ask for help to our knowledge, to our experience, and also to the logic of a rational approach. Thank you very much for your attention.
We thank you a lot. Very nice presentation, really. Probably Mauricio can ask questions.
Yes, Massimiliano, just a very simple question. Which is your personal opinion about performing or not duroplasty and entering or not arachnoid layer? In a short way, your personal view of the problem.
Thank you for your beautiful question. This is still matter of debate, as we have commented. My personal experience is that to open Dura, to enlarge, for sure, to enlarge the posterior cranial fossa is the best chance. When I open the Dura, I always want to check with the microscope. And by checking, if I see and I recognize some arachnoiditis or thickness of the dura, I'm there. I have this microsurgical armamentarium. I explore. I cut the breeds, the arachnoid hypertrophy, and I try to complete my surgical strategy in the deepness. When I don't see anything that can impress my interpretation, I try to perform a huge, consistent duroplasty. Better if with autologous substitute like fascia lata or a pericranium. Around 80–90% of CSF leakage reduction with autologous closure compared with a Gore-Tex or a cadaveric or a heterolog patch. A main concern is for tonsillar shrinkage. When you deal with the arachnoid in a few seconds, you should be forced or pushed to coagulate from the internal aspect, both the tonsil, in order to improve the surgical results. Nevertheless, we know that there are some risks linked with the possibility to injure the pica artery and also to produce or induce recurrences of arachnoid reaction, since you manipulate in a iatrogenic, cruent manner the local environment. And so probably when you cut the breeds, the arachnoids, we cure a problem, but when you coagulate tonsilla, you create a new problem. And so just to cut arachnoid should be advisable, my personal opinion.
Massimiliano, there are many questions from participants. One question is that If it fails, the decompression for syringomyelia, what is your option? Do you perform a syringo-arachnoid or syringo-pleural or peritoneal shunting?
Good question. Thank you very much. And this is a second topic, still matter of debate. As a matter of fact, to open the syrinx is the cure, obviously, no doubt about that. But we also know that when you open the syrinx, you can have a transient success, which could be completely overcome by natural healing processes. In this way of management, I prefer to put a catheter inside, a silastic catheter inside, and to perform a local syringo subarachnoid shunt. Many other options are available, also drainage of syrinx in the pleura or in the peritoneum, but personally I'm not so confident about this strategy, since when you cough or when you have to perform a bowel activity during the day, you can change the local pressure, and you can worsen also the local CSF dynamics. I will never forget what happened when I was a resident and I was helping a senior surgeon who put a drainage inside the syrinx, and the other hand of this drainage was put in the fourth ventricle. The day after surgery, the patient was tetraplegic, and it was performed a CAT scan. At that time, there were few MRI devices in Italy, and what popped up was an hydrocephalus. We had under anesthesia before surgery. This was a typical hydrocephalus linked Chiari and Syring malformation, and we didn't correctly perform the diagnosis before surgery. And so, since we didn't correct hydrocephalus, we couldn't relieve tetraplegic complication in this unlucky patient. So first of all, to make the right diagnosis, is it a real Chiari 1 or Chiari 2 malformation, or is it a Chiari formation according to Goel philosophy due to hydrocephalus? In the second situation, you should avoid to perform a shunt between still active hydrocephalus and the syrinx. Otherwise, you worsen the clinical pattern of the patient.
Another one, do you ever look at the OBEX? It was a historical treatment. There is one question from participants.
I'm sorry, can you...
do you ever look at the OBEX?
OBEX, yeah, OBEX, yeah. A good question. When I explore, and I explore in the deepness of the surgical field, why not check also the OBEX? I do it. I check the OBEX, and just in case I see there is something I don't like, as arachnoid new production arachnoiditis, I try to debride it. Yes, for sure.
What do you think about the craniocervical fixation? Actually, C1, C2 fixation for Chiari malformation.
Yeah.
Do you also apply this technique in certain cases, or you didn't start it yet as Atul Goel is advising for all cases, as you know.
Yeah, I'm in love with these very original philosophical and scientific, strongly scientific interpretation. I trust in the fact that instability can produce Chiari malformation. Instability acts like a depressing and sucking hydrodynamic phenomenon inside the brain and the craniocervical junction, so producing tonsillar descending reaction we call Chiari, but is a Chiari formation, not malformation. So two instruments to fix instability is the right cure for this extreme condition. But sometimes, and we have shown that not all the Chiari formations deals with the C1, C2 instability. Sometimes when I have not the proof, of instability, and the proof means a dynamic flexion, extension, lateral bending, craniocervical neuroradiological assessment, when I have not the proof directly or indirectly, like the fluid collection of in the articular facets or other indirect sign of instability, I am a little bit more prudent, and I try to tailor different strategies for different etiology. That's my personal take-home message. Not all the Chiari are produced by the same etiology. We have to identify clearly the etiology and to cure the etiology. For instance, you remember the case of the young patient with hydrocephalus and secondary syrinx and the Chiari formation. In that case, to fix C1, C2 is completely unuseful, because the cause is hydrocephalus. As soon as you drain hydrocephalus, you solve the problem. Just shunt it. And also, in some special case associated with tether cord, just untether, and the tonsils rise up. All other cases, I think, that can be studied for instability and eventually operated with instrumentation and fusion technique.
You mean if there is some criteria, stabilization will be an option? Not in all cases. Do you mean that?
Yes, I think that in all cases I have presented in this seminar is not equally effective C1, C2 instrumentation. I'm sure that Atul agree with me when again we speak about hydrocephalus as a primary driving force of syrinx and the Chiari formation or tether cord. I think he agree with him. As I agree with him in all other situations in which a C1, C2 fixation should and
in fact, these were the provocative questions for Atul. Yes, I think Mauricio can present the next speaker. Mauricio, are you there? Mauricio has...
Yes, I'm here.
Good. Okay.
Okay, so let's go to the next